Good morning, ladies and gentlemen. Good afternoon, good evening. This is Dr. Sasha Jovanovic from Los Angeles, from the Guide Institute. Today, I will show you the treatment of one of my patients, which you can see already here on the screen, which has a pre-existing condition of a cervical resorption. As you can see, it's going from external to internal. And at this moment is also giving the patient some pain and sensitivity. And it has progressed over time to a larger lesion. The plan will be to replace this tooth with an implant and, if possible, to do an immediate tooth replacement. Interesting here is that in this healthy patient, there's an existing implant, as you can see in the lateral incisor position, which I had done for her more than 10 years ago. And the patient lives in another part of the United States, but called and wanted to be treated again here. And so I, of course, welcomed her back, and we're working here on this condition. Let's look at the patient. You can see that there is a coronal gingival margin, which is more apical in the tooth number 8 versus the tooth number 9. We diagnosed the patient for a possible also lengthening of the gingiva, and we also looked at the option to maybe improve the vertical length of the teeth with some incisal lengthening. So let's look first at the patient, the way she looks. When she smiles, as you can see, she shows some tooth display, but in a rest position she shows no teeth, and she's still fairly young and healthy. So we were displaying to her that she had really like a short anterior teeth. When we move into the smile progression, it's even better to see here. In rest position, no tooth display at all. At a small smile, she's showing like a little bit of the tooth display, and then really on a big smile, she's showing just the incisor edges of the teeth. The same in a view on the lateral. You can see that here. And of course, also she has a little bit of a dropping of the lip on one side versus the other side. When we look at the view of the clinical condition, you can see here the central incisor that has a healthy band of keratinized gingiva, has a good circular position, but of course in comparison with the number 9, which is very short, this condition is somewhat on an more apical position. We discussed with her that probably the easiest way to control this for her would be to lengthen tooth number 9, so the healthy central incisor, and to do some surgical crown lengthening for her after the healing of the implant. Tooth number 7, where she has an existing implant, looks very good, especially if you think about plus 10 years. Maybe a little bit thin on the gingiva, but at this moment, we could probably increase the thickness on this tooth by adding some soft tissue at the time of implant placement. Here we can see again the condition. So there's the cervical resorption, which you can see, and you can see the x-ray, which displays the number 7 implant. This is a Noble Active with stable crestal bone, moderate bone reduction, but still very stable. The abutment which was used for her was, as you can see, a titanium base with zirconia, and then a crown on top of that. Looking at the aesthetic mock-up, this is what we did for the patient, so the patient understood what could be done for her. Notice here how we lengthened the tooth number 9, so it would come to a normal cervical margin. We didn't do too much to the cervical part or the gingival part of tooth number 8, but we lengthened both number 8 and 9 by 1 millimeter. So you can see that this already gives the patient a much better functional and aesthetic comparison, especially when we look at the lateral incisors. We also are looking at a little bit enlarging the lateral incisor because it has a very triangular type of shape to give it more like of a tooth shape of a lateral incisor. So this is the mock-up where the patient can really look at, and she really appreciated this and didn't know that it's actually possible to change her aesthetics with so minimal invasive therapy. So here you can see the direct aesthetic mock-up, and again, you notice here that in the rest position of the patient, on the left side, no lengthening of the incisal edges. On the right side, you can see just in rest that she's showing already like a nice amount of positioning. Also here with the direct mock-up, you can almost see how the patient is already happier and smilier and shows much more beautifully her anterior teeth. And so this is something that, if you compare it to the before and after, it's really a drastic change. And this all is done in one appointment for the patient, just to show the patient what is the plan that we could do for her to improve this. And here the final improvement, as you can see here, really nice to see the improvement in the aesthetics on the number 9. And of course also much better for us when we're thinking about the implant. Now we're looking at the implant itself. So we want to look at the tooth that needs to be replaced. We also want to look at the crown lengthening. So how much of the bone needs to be replaced in a patient like this. So in our digital planning, this was done using the Studio DTX from Nova Biocare. You can actually really have a really beautiful amount of display so you know how much bone you have to remove. And here we can see the cross section where the tooth will be replaced. This is the tooth number 8. And you notice here that the planning will be to place a 3.5 millimeter diameter implant with a 13 millimeter length. And we're placing that 3 millimeter from the ideal gingival margin. And the ideal gingival margin in her case will actually be the cervical margin that she has on the teeth in that position. And here you can see that even better, where we're placing the implant in relationship to that front part. And then we're moving into the surgical planning. This is the surgical guide that we have made for that patient, so it really looks good. It's stable on the adjacent teeth. And again, we're maintaining the gingival margin the way the patient has it right now, because always thinking that we will, for that patient, lengthen the number 8 tooth, the natural tooth. So we're going into the surgery now with this information that we will keep the gingival margin on the tooth to be extracted, and then once the healing is finished, we will change the crown length on tooth number 9. We'll improve the incisal edges, and of course I'm going to try to thicken a little bit the gingival margin on the tooth implant number 7, where it's quite thin. So let's go now to the live surgery so you can see how we actually treated this patient. So we're going to start first with extracting the tooth very, very carefully. So here's the extraction treatment. So I start first with a gentle cut with a microsurgical blade placement. This is a 15C that I'm using, and I'm going through the periodontal ligament fibers, and I'm moving into the bone space, so basically into the ligament space, to separate any fibers attaching to the root itself. I do the same thing on the palatal. The patient has received for anesthetic a pretty simple treatment, which is local infiltration anesthesia, and I use for this patient Septicaine. She has no allergies, healthy, non-smoker, and no periodontal disease. Here's the cut, again, that's going through the sulcular and gently separating, again, the fibers that we have here. Now we're moving with the second instrument. This is a piezo surgery instrument, and I'm using this as a periotome. So you can see how the periotome is moved through that space that I have already opened up with the scalpel. And now the idea is of this periotome in the piezosurgery to move gently into the periodontal ligament space and widen the periodontal ligament space without jeopardizing the buccal bone plate. Because remember, the buccal bone plate in these anterior teeth can be and usually is very thin. We have this beautiful paper from the University of Bern who showed us that 90% of anterior teeth have a buccal plate which is thin, so less than 1 or 1.5 millimeters, or missing completely. So here's loosening the tooth. The same thing we're doing also on the mesial, and we'll do the same thing also on the posterior. Here we can see the distal being loosened. Careful, I don't want to jeopardize any bone. So this will really go into the spacing between the teeth. Checking if there's already some looseness. Then loosening from the palate. Usually the bone is thicker on the palate, so here we can be a little bit more generous in the overall positioning of the piezosurgery unit. Here you can see that. A lot of copious irrigation. And then we're moving to the next instrument, and the next instrument is a gentle application of an elevator. And this particular elevator, of course, is not supposed to put too much force, just to loosen it. And then we're moving towards a forceps, which has, again, the same motion, a slight rotative motion with absolutely no pressure on the buccal plate. So the goal is really to not jeopardize the buccal plate at all. So very, very gentle movement, but you can see that this sequential treatment of cutting the periodontal ligament with the scalpel and widening the space of the periodontal ligament with an piezosurgery, and then loosening it slightly with an elevator, and then very small non-traumatic rotation with a forceps can allow you to remove a tooth like this with quite a long root out without any kind of trauma. So here you can see that. Here you can see the cervical resorption quite beautifully. So I will put the probe there so you can see that. Look at this. That's all like inflammatory response that the patient has, and that's the one we removed. Then next step will be that we're going to be cleaning out the socket, and this we usually do with a hand instrument and with a surgical instrument. So the hand instrument is a Euphrides surgical spoon. We remove all the excess of inflammation tissue, and you can see that very carefully removing that. Of course, I want to see bleeding, so that's great. Here you can see that I'm removing gently all the soft tissue, periodontal ligament tissue. Then I'm checking here with my periodontal probe, my 1 millimeter increments here, that actually is the crest of bone within 3 millimeters, following the biological width principles and biological height principles from the gingival margin. Because remember, I want to maintain that gingival margin where it is. So here it is. And here's the check. The periodontal probe shows that the distance Okay, that looks good. So all the bone is present, so we have not lost any of the bone from the extraction site. That looks excellent. So we're going to follow this bone, as you can see here, with the periodontal probe. Now, this is my next instrument. This is also a piezo surgery. I use this with a round diamond burr. And basically, it has the same objective as my Euphrates surgical spoon. I'm trying to clean out the socket as good as possible. So what I'm doing here is removing, again, any inflammation tissue, removing any soft tissue, and removing any kind of periodontal ligament tissue. And of course, I do this with a round diamond, and this will help me to clean it out. Here is my preparation, which we did. When you look here, I made two different shells here. This is done in collaboration with our prosthodontist, Dr. Francesco Mitroni. And the left one will give us already a shell for the eventual temporary crown. And the right one is my surgical guide to place the implant. So we basically made two shells which have cantilevers, so they're stable on the adjacent teeth. And this which is what we're going to use in the surgery and in the post-surgical treatment. This will be our surgical guide. And the second one could also be a surgical guide, but it can also be used as a shell for the temporary. And then we'll use that to fill this up. So now you can see the surgical guide being placed, really nice and stable on the adjacent teeth with these cantilevers, which are on the incisal edges. You can see how we have duplicated nicely the gingival margin. You see that's perfect. So on the number 8, on the central incisor, the position looks really nice. Here you can see the palatal opening. So we have to make sure that, of course, the implant emergence will be palatal to that incisal edge. Here you can see our second surgical guide, or it could be the temporary shell, which was also laboratory fabricated, and which we're going to be using to stabilize, of course, the temporary to the implant, which we're going to be placing. Now, next step will be to evaluate that this site is ready to be treated. So we're at this moment in a position that this is good. So you can see here looking at the site. Surgical guide again. Patient is checking already. Probably thinking, are we finished yet? And we still have a little whiles to go. And now we are coming in, as you can see, with the burr. And the burr is, my first burr is like a precision drill. And I could do this guided, or I can do this freehand. At this moment I'm doing it freehand, but of course, like my aid or my help here is the guided surgical stent. You can see my positioning has to be really, really well positioned between the roots of the central incisor and the implant of the lateral incisor. And this can be done nicely. You can see I'm following the trajectory of the palatal bone. making sure that like my exit of this drill is going through the palatal side of the tooth. You will see that in a moment. Now we're checking again. We're placing the surgical guide on this. And you can see how the drill is coming already through the palate here. You can see that beautifully. So we're maintaining this position and at all times trying to maintain this straight position through the palatal side of the implant. Now we're ready for the second drill. Here's our second drill. This is a 2.0 millimeter drill. And we have to calculate a little bit here because the implant length is 13 and the soft tissue dimension is 3 millimeters. So basically from the gingival margin to the implant depth, we have to go 16 millimeters. And at this moment, because it's a small drill, we can even go a little bit deeper as long as the anatomy allows us. But the ideal depth is 16 millimeters on a 13 millimeter implant. So our second drill is in. Now we check again the positioning. Here's our third drill. Again, we're following the same depth guidance. So the depth guidance here is that we will go to the 16 millimeter measured from the gingival margin. That's good. And at all times I'm placing the drill back and I'm checking it with the surgical guide. So this is just my own personal quality control that I maintain that palatal position of the drill. And I'm still in a good position, as you can see here. I'm palatal through the site of this incisor ledge. So this looks really good. It's a 3.5 millimeter implant that we're planning. So the last drill is probably going to be somewhere around maximum, I would say, 3 millimeters. So we have a little expansion. But I probably would go, if the bone is soft, maybe go maximum 2.8. So we have a 0.7 millimeter expansion into the bone. Here's the check of that. So you can see I'm frequently always making sure that we're happy with the three-dimensional position of the implant. The depth is also excellent, so we're good. And again, the depth is not as important as long as the anatomy allows me. I can go a little bit deeper if needed because it's not going to be something that I'm going to be using in the final implant position. Here we can go and evaluate the site. And checking this. And here comes the implant. So that's my 3.5 millimeter diameter, Noble Active, narrow platform by 13. And I'm helping myself with the guide a little bit. Then that's my implant. Checking just the position. I want to make sure I'm in the right position. Here comes the implant. Up. Because this is freehand, I'm just evaluating this carefully. Remember, this is an aesthetic implant placement. So the more confident I am to place the implant in the accurate position, the better it is. That's a 2.8 millimeter drill. I'm just checking again here the position. So I'm giving myself an eye matching control. So I want to see exactly where is this drill ending. So here you can see this is all like I'm just doing this freehand. So I'm checking where's the drill in relationship three-dimensionally, and then I can go and move in with the implant. So here's the implant, and I'm actively guiding it with my hand, and I'm having a little bit of trouble here, as you can see, feeling comfortable with placement. And I'm coming, there's something which I don't like in the internal part, which probably is like the amount of implant that I can move in here. So I've used a slightly larger drill just to open up the crest of bone so the implant can move in easier. So now this looks to be, when you just see now here the implant positioning, that looks to be the positioning of the drill. So that this is better. So I've worked hard with the surgical guide and even with a little extra adaptation of the drill to place that implant in the accurate position. So now we're moving, and now I should slowly but surely be able to engage this. There we go. Engaging. And the horizontal line which you see here on this implant is 3 millimeters from the top of the implant height. So now I'm not yet fully seated, so I'm going to be fully seating this here with a hand torque device. And but before that, I will just check the surgical guide. I want to again be sure that the implant is in the right position. Now, there's the implant. You can see nicely the gap on the buccal, so the distance of the implant from the buccal surface to the implant to the palatal surface of the bone. They're also checking the visual there and controlling that. Here's the view, the occlusal view, that looks good in relationship of the implant. And now we're going to be placing the implant in the optimal vertical position. So remember that horizontal line of the implant needs to be placed at the same level as the gingival margin. So here's the view that we will do. I'm slowly torquing it into position, holding it really in place. I don't want this to be somehow going in the wrong direction, because implants sometimes, when they have minimal bone, they can look for the path of least resistance. So I really have to use some careful evaluation. I'm checking here that there's enough open space between the implant and the buccal bone. Checking again with the surgical guide that this is properly following the tooth position, and it is. Then replacing the cover screw. And the cover screw is important for me because what I'm doing is I'm actually closing the gap to the implant. So when I place the bone graft there, it will not disappear into the implant. Here I'm using a special little trick. I'm activating the bony walls with bleeding. So I'm using a precision drill, and I'm staying away from the implant, staying away from the adjacent roots, but I'm just perforating the cortical plate of the extraction socket to gain some extra vascular supply. So the blood flow, as you can see coming in here, needs to be activated, because all the healing is going to come from the blood. So that's kind of what we're doing here. We're increasing the angiogenesis in this area. I've used here in this patient a biomaterial made out of xenograft, and that's the commercial brand BioOS. And you can see small particles that I'm using here, not the large particles. And just with small volume, I'm applying them to fit around the implant and exactly into that gap. And you can see also how the bleeding is occurring at this moment, so that's good. And all the white particles have, of course, now been surrounded with blood. And of course, as the blood vessels will be coming in, they'll be taking advantage of all this particulate, which is porous, and move into this area. So I'm using a small carrier, and I'm using a small condenser. This condenser is about 1 millimeter wide, so really thin. And I can apply that with light pressure onto the biomaterial and really carry it into the depth of the extraction socket. So that's looking really good. You can see that. Nice. You can see the bleeding. I try not to suction this too much. Number one is, of course, you will suction the biomaterial away. And number two is, of course, you also dry it up. So here is a good visual of the bone. You see that, the cover screw? And then buccally of this cover screw, you can see how I transplanted the bone into this facial space. So that's really good. That will maintain the thickness and the contour. So that's a nice view here. And we're ready. I like that. Now I'm removing the cover screw from this area. The torque on this implant will need to be at least 40 Newton to do an immediate abutment placement and an immediate temporary. The abutment that I'm choosing to use here, because I have enough space, is a titanium stock abutment from Nobel Biocare called On1. So it's basically a short abutment. It's like an 1.75 millimeter height of gingival cuff. So it's kind of very limited, but in a very good way. So here you can see that. This will be a connection of the implant with the platform towards the crown itself. So at this moment, you can see it's 1.75 millimeters height, so I still have 1.25 millimeters plus to distal the gingival margin. Here I'm torquing it down. This particular abutment allows you to torque it down to 35 Newton, so that's good stability. So of course the implant has to be more stable than 40 or 45. And that's why we're using a Nobel Active implant here to get good stability. And it's a stock abutment, so it's pretty easy to order this. And all the custom work will come on top of this. But it's a stock abutment, so it's not custom. So that means that you need to have a little bit more space. It doesn't function really well in narrow spaces. So I wouldn't probably use it for lateral incisors or for lower incisors. But for a pretty normal width central incisor, you could use it. And of course, like for premolars, you could use it. Here's the visual. Now the next step is, so we have placed the implant, we have placed the biomaterial, the BioOS, and we have placed the base abutment. So next step will be is that I'm going to make a tunnel procedure using a microsurgical blade leaving the papilla intact to receive an autologous, so a patient own connective tissue graft, to thicken the buccal gingival margin on the tooth that we just removed, so on the new implant side. And because the implant, which is 10 years old, you can see it's a little bit thin in that area, I'll thicken that as well. So this is a nice procedure. As you can see here, we're moving in with a gentle microsurgical plate. You have to be very careful so that you don't displace the papilla or cut the papilla. And then I'm actually using here, as you can see, just a simple periodontal probe to complete my tunneling procedure. And what I want is I want that soft tissue, here you can see that, to be so loose that I can move it coronally. Here I'm using one of my microsurgical pliers, which are very efficient and very atraumatic. Here you can see that. The coronal repositioning, nice in this area. And here's the tunnel. And you can do a lot of like loosening of the tissue with a blunt instrument or with a sharp instrument. If you work with a sharp instrument like here, of course be very careful because you have to really pay a lot of attention to detail. I have to be very meticulous so you don't do any kind of miscutting in that area. Then we're moving to get the palatal tissue. So remember, I want to thicken the buccal plate and I want to thicken the buccal plate on the center incisor. So I'm on the palatal side of the upper right, so close to the implants. I have separated the outer epithelium and connective tissue. I leave about 2 millimeters in space. And then I'm doing a split thickness flap where I'm able to remove only the lamina propria and the dense connective tissue from the palate. So I'm basically using the typical periodontal plastic surgical approach of an subepithelial connective tissue graft. And I'm staying away from the periosteum. I'm staying away from the bone because that's also where, of course, more nerve and more soft tissues are, which are bleeding. So I just want to show you that's your soft tissue right there. So that's subepithelial connective tissue graft, pretty dense. You can see a little bit of fatty tissue here, but we're going to use all of this here for the patient. And this I'll place into a saline bath or just like in a very heavily wet and hydrated saline surface. But I can also just immediately move that soft tissue into the tunnel. Of course, be careful that you don't suction it away because it's very important. Here's the horizontal incision on the palate. First thing is always that I move into this space and put pressure on here. Pressure like for about 2 minutes is excellent. And then I'll use sutures which are non-resorbable monofilament. So they could be either a PTFE suture. I like to use the Cytoplast, really nice. 4.0 is really good for this. But you can also use nylon. You can use microsurgical sutures as well. But I like to use this cross-arch horizontal mattress external suture to put some pressure on the external flap, which really helps us to stop the bleeding. With this technique, which I've used for many years, like more than 20 years, I have really learned how to control the bleeding in this area. So you can see there's pretty much after one suture already, any bleeding, if it occurred, will stop. So that's a nice benefit of this particular suture. And there we go. Look, that's 1, 2 sutures only, but I'll probably place one third one just to be like, on the safe side. and put again some pressure, hemostatic pressure with a gauze to stop the bleeding. And then on a healthy patient with good hemostasis, the bleeding will stop pretty much immediately. Here's my connective tissue graft. What I will do now is have the goal and focus to move the soft tissue graft into that space, the tunnel. So this is the surface. Now, of course, we have to go underneath. And I'll use specific sutures for this. Again, these are microsurgical sutures. These are monofilament sutures made from nylon. And I will apply them in a position that they will be able to control the position of the connective tissue. So here's the first movement. So this is a sling suture, remote sling suture, which exits through the tunnel, in this case through the sulcus. Then it goes underneath the sulcus again, and it will exit in the extraction socket space where the tooth will be replaced with a temporary and has already the implant. Now I can attach the needle and the suture to the connective tissue. So this, of course, is a very fine treatment, and you have to really work very carefully. Also, like, you have to have stable hands here. So you need also good help. Some tremor, some shaking, of course, is normal, especially in the beginning of learning these techniques. Also depends, of course, if you just had a coffee, some caffeine before, that's probably not a good idea. But you can see how I grabbed it. And now the next step will be is that I'm going back with the needle in the same reverse position. So I'm coming now from the extraction socket, and I'm exiting through the sulcus. So that's just a reverse step. And I'm looking for the sulcus. And I think, yeah, I found it. Here's the needle. I'm pulling the needle out. I like to go reverse so I don't have the sharp side of the needle because it will grab some tissue. And now I'll start to have the suture there. Then I go through the sulcus. Again, I will exit in the apical space. So it depends a little bit in where I want the soft tissue graft to go. So remember, this is a sling suture, and it's going to be pulling the soft tissue graft in. Now notice what's going to happen. I'm grabbing the suture with the plier, and gently I'm pulling the connective tissue graft into the space. So let's see if this will happen. This is very, very microsurgical. So I've made the tunnel, so now we just have to see that the tunnel actually is precise enough and loose enough. I'm helping a little bit the position. I'm using here one of my Joe 1 instruments. Of course, there we go. It's pulling it in, and there it starts to disappear. And now you can see how nicely that connective tissue will thicken the soft tissue around the old implant with the old crown. And you can see the soft tissue right there, thickening the space of the soft tissue. So that is looking really good. Okay, so now we'll need a second suture. So we'll just like tie this suture now off with a knot. I'm happy with the position here. And there's the knot. We'll do 3 or 4 knots. There we go. And now comes my second suture. So this will be pulling the connective tissue towards the opposite side. So I'm basically spreading the suture in two different directions. And here we go. So that's positioned. And then I'm going to be using one more suture to stabilize the crest. So let's see what this suture will do. So I'm having now a nice horizontal spreading of the flap. And this one basically I'm attaching and stabilizing the connective tissue towards the buccal flap. So that's a nice positioning. You see I went through the connective tissue. Yeah, that's looking good. And thickening the area and stabilizing again. So 3 sutures will do the trick here to stabilize that flap in the buccal and lateral way and thicken the soft tissue on the existing implant already. Good bleeding internally, so that's good for the healing. Nice visual here of the 3 sutures. And here's the visual. You can see how stable this is in this particular site. Excellent. So we're ready now to basically complete the temporary. We're using a titanium temporary abutment. And here's the shell that we talked about. So this is now the work. At this moment, the work is being further taken over by my colleague and prosthodontist, Dr. Mitroni. And we're working here in a team effort. And I'm working here at the same time, so we're just executing this here together. Here you can see how the implant really comes beautifully through that occlusal space, so the implant is in well positioned. Filling the temporary titanium abutment, and now we're going to be ready to fill the space of the temporary with an acrylic or composite, and to basically do a pickup. So you can see that, just a final check. Again, we're not changing the gingival margin. This is where we want the gingival margin to be. And here is the flowable composite which we're using. Just to show it to you, that's the flowable composite being applied here around the abutment. So of course we're being very careful not to go into the abutment space. So it's going surrounding. Then some hardening with the light. Checking that we are picking up everything. So now of course it's retained, right? The acrylic has hardened, has taken advantage of the undercuts of the abutment. And then we're removing this. There's a little bit of stability here, which needs to be removed. Making sure that it has the right position. All this now will be, and here we go. So it's being removed. The connective tissue graft is still in place. And now we're placing a temporary abutment, just so that we know we have. And here's the first try-in of the temporary. So now there's going to be a work around this particular temporary. So more composite was placed around that tooth in outside of the oral cavity, so on the lab bench, then adapting it to the dimensions that we need for this tooth, making sure that, like, of course, it follows good functional aspects, no occlusion because it's an immediate tooth replacement, and also in protrusion and in lateral. So this is very carefully done. So sometimes these immediate tooth replacements can be a little bit shorter in aesthetics, just because of we don't want to have anything jeopardizing here the pressure of the bone. And these are just the tests. Now the occlusal habits of the patient, controlling that. There's about a 2 months period that the patient will have to be very careful with any kind of pressure here. So it's really more of an aesthetic, a visual for the patient, this temporary, as well as like maintaining the soft tissue emergence. So being careful. No contact. Also, the contact with the adjacent teeth has to be very light. We're slowly coming here to the final temporary. Position. Again, she has a little bit of a deep bite, so you have to be careful. That's protrusion, checking that. You can see the color match is very nice for this patient. And she will go home with obviously a tooth which is really beautiful. We're almost ready. So here's the contour of the tooth. It's under-contoured in the subgingival space, so we can maintain all the soft tissue thickness. You can even see some translucency here in the temporary. So that's why I like when these temporaries are made in the laboratory, because you can really get a really nice positioning. Now, because the tissues are loose, what I like to do is I like to move the flap margins a little bit more coronal, because as the tissues are quite loose, I don't want like possible detraction of soft tissue as well as maybe some muscle attachments to pull the soft tissue margin in an apical direction. So you'll see here now, as a final touch, what I will do is I will, after the temporary is completely finished, I'll come in with one last suture. So here we are. Final prepping. Of the site. Polishing. And some glazing with bonding. And then you'll see what we're doing here, just for the patient's positioning. And remember, I never removed that titanium abutment. That always stayed in place. can see the soft tissue margin being quite loose. Closing the opening of the palatal side. So again, checking, because you added some composite on the palate, that there's no occlusal interference. And here's what I want to show you as a final. So I'm moving now a suture through the buccal space. I don't need to go to the connective tissue. I go quite deep with this suture. It's pretty much a full thickness suture. And then, as you can see, I'm moving it in a coronal direction. So this is a coronal repositioned suture. And it's bonded towards the central incisor or lateral incisor with some flowable composite. And the pressure is now going into a coronal direction. So if there's any kind of shrinkage, it will be more natural. Because I've loosened the flap so much internally, I don't want to have a risk that it's like moving apical. So, of course, this is maybe a little bit of a disturbance for the patient, but, you know, with just initially already giving the patient an idea of what this is, and explaining it to the patient, this will be a good way of finishing the case. So by this here, we finished the patient treatment. At this moment, we have moved the patient now into a much better position than before. We have moved the gingival margin, thickened it, controlled it. We have placed the bone there so it supports the buccal plate. We've placed the soft tissue there to make sure that it has a good thickening on the old implant and on the new implant. And of course it's really nice in overall positioning. So we have protected really from any kind of resorption. Now the next step is that we'll remove the patient from a standpoint of we'll have the patient be very careful for the first 2 months, because as you can see here from the initial start of this patient, we need to protect that old implant, and of course we need to protect the new implant, and we want to maintain the soft tissue margin. So 2 months I'll be very careful. Then about 4 months down the line, we'll start to remove the temporary, and we can leave the on-one abutment in place, just make sure that it's really secure, and then we make the final crown. And this is what we did in this particular patient, and the tissues are stable at the 4 months period, and really nice. I was hoping to show you the final, but the patient is not living in California, and unfortunately with the current conditions we're in the world, she was not able to come back here, but she's scheduled for the summer to come back after everything calms down. So from this standpoint, we'll go now into the discussion, live discussion, and I look forward to receive your questions and to answer them satisfactory, hopefully, to you. Thank you very much. So now, for those of you who have seen it, I think you saw a very interesting treatment planning case, because it flows nicely with the extraction socket masterclass that I'm giving and presenting at this moment, because it was an anterior, so central incisor, immediate tooth replacement with an immediate implant and a simultaneous socket bone graft with a xenograft biomaterial and an immediate or simultaneous connective tissue graft, which was used in a tunneling procedure to augment the buccal soft tissue on the new implant, which is like the center incisor, and then thicken the soft tissue on the existing implant. And it's actually really a complicated case, because if you look at the indication of where the implant had to be placed, it was right adjacent to already an existing implant. So to preserve the tissues in a case like this, it's really hard. Actually, I just saw a patient yesterday that I did a similar procedure. It was also like a central and a lateral, just on the contralateral side. And she came in 10 days after for post-op healing. And she also preserved her gingival margin perfectly. And so we're doing, at the early healing stage, is really good. What was also interesting in the case, and then we'll just open up the discussion for you, I have been used to using a custom zirconia abutment, which we would pre-plan based on guided surgical principles, or just on laboratory planning, where we would look at the gingival margins and then accept to place the implant about 3.5 millimeters apical to the gingival cervical margin, and then design the abutment as such. So even before we place the implant. But now I have this stock titanium abutment, which is called in the Nobel Biocare product line an on-one abutment. I believe that there's other companies like MIS who also have something similar, or maybe 3i, I'm not sure. They just call it differently. The way, for the purpose of the presentation, of the discussion, let's call it a low profile titanium abutment, because the height of that gingival abutment is in the on-one, in the Nobel Biocare one, it's 1.75. So that will go from the height of the implant to 1.75 millimeters higher. So you're still about 1.5 millimeters below the gingival margin. And that's where you can do your emergence profile and where you can make your dental restoration. So that was done in this particular case. And then you can see that with the shell that we had, we made an adjustment of the temporary crown, and we used a titanium temporary abutment, and we made it screw retained. So all this worked out great. She has been healing. Unfortunately, she's not been a patient who has come back frequently, because she lives in a state which is, I think, 3 or 4 hours flying from Los Angeles. And she was supposed to come in during the COVID-19 highest month. So like that, she didn't do that. And then she was supposed to come in a few weeks ago, and she rescheduled again. And I think she's now scheduled to come in at the end of June. So then I'll have a follow-up on that. But she's doing good. She's been sending me like iPhone photos, which kind of is, works for like just general purposes. And she has no symptoms. She has no negative comments. So everything is really positive. Also interesting in this patient, of course, is that the cervical margin on the implant, the new implant site, is apical to the natural tooth center incisor. And so our plan is to do a surgical crown lengthening on that center incisor number 9 when she comes back. And so we can make the mock-up, or we can follow the mock-up idea, which we had in the beginning, to have the center incisors at the same equal length. So she wants that. She's not very aesthetically driven, but of course, when she saw the difference in lengthening the incisal edge and lengthening the gingival margin, she was very, very happy. So these mock-ups are really, they take very few of our time, but once patients see that, they go, oh, wow, I can have that. So those mock-ups are really great tools to communicate what sometimes we have, but we don't, we can always communicate this. So that was my review of the case. Now let me ask you if you have particular questions regarding the treatment, maybe regarding the diagnostics, the steps, and also the temporary. I'll wait for any of you as a question. You can just open up the microphone because we're in a small group of 24 at this moment. I'll maybe start the discussion with a chat question which came in. And from Shadi. Shadi, thanks for the comment here. And so your question is, during the tunneling procedure, the thin buccal plate will not be affected? And how many weeks we leave the buccal suture that pull the tissue down? Okay, so let's answer the easiest part of the question quickly. So the sutures which are moving the flap in a coronal position, so the coronary position sutures with, which were bonded to the tooth with some composite, some flowable composite, I would say a minimum should be 2 weeks, and anywhere up to 3 weeks is sufficient. So that will give us sufficient stability of that area. If you can keep them in longer, if the patient comes back and you can see that really the tissues are holding up nicely in a coronal position, I have really no problem, because this is a monofilament thin nylon suture, to leave them in position even longer, because as long as the patient can just clean them with a very soft Q-tip, you could leave them in. So absolute minimum would be 2 weeks. Anywhere like around 3 weeks, I would probably start to remove them. But if I see that everything is like really doing well, and it's also that I have a patient who is easy to come back to my office, then I would maybe leave them in even for 4 to 6 weeks, because I can stabilize the tissues better. The second question of Shadi is, does the tunneling procedure affect the thin buccal plate? So the thin buccal plate will definitely be affected a little bit with a tunneling procedure, but it's kind of minimum, because you have like two extremes, right? One is to open up a full thickness flap, which of course we're not doing in this case. But if you open up a thin buccal plate and you remove all the periosteum and flap, you're going to lose probably about maybe a millimeter of the surface of bone. If you don't touch anything, so you leave it attached, like we do in an immediate tooth replacement flapless, you're going to lose very little, but you're going to lose also a little bit from inside, because you get this remodeling of this bundle bone. If you're doing the split the way I did it in the tunneling procedure, the goal is actually to leave the periosteum on the bone. And I'm so sorry. I had to sneeze there for a moment. If you are removing, so you're leaving the periosteum in there, you're probably affecting it very little. And also, of course, the whole purpose of the tunneling procedure is to also thicken it with the connective tissue graft. So I think if you lose a little bit, you're compensating it with the connective tissue graft. If you're losing a little bit from inside, because the bundle bone is very delicate,
you're again compensating that by putting some xenograft in there, so some bioos. So both of them are being compensated quite nicely. I hope that answers the question. Then I have another question here from Peter Chen. Peter is asking regarding extraction sockets, how to ensure optimal condition for immediate implant placement. Yeah, so Peter, I don't know if you're part of my current online masterclass for extraction sockets, but that's kind of the discussions we're having there. And I gave already one live session there, which I know some of you are part of, because I recognize the names and I recognize the colleagues. So you just have to always remember that for immediate implant placement, an immediate implant placement has two options. It means to place an implant at the same time of an extraction site, so right after. Then you need to like have two pathways, right? You're getting two pathways. One is going the route of that you're not raising a flap. So the idea is to do everything flapless and to preserve everything. So it's a socket preservation. But to make sure that this is a good extraction socket for this purpose, you need to have the bone intact, buccal bone intact, and you got to have the soft tissue intact. Like in this patient that I treated, which we watched today. If the bone is compromised and you have no buccal plate, moderate or severe, then of course you can still do an immediate implant placement, but at that time you have to raise a flap, so a full thickness flap, to have full access to the bony condition of the socket. Then you can place an implant, and then you can do a simultaneous GBR. Usually when I do an immediate implant placement in an extraction socket that is compromised, so I have to do a GBR, I also do simultaneously a connective tissue graft. And then I submerge everything. Because then I'm reinforcing the bone, I'm going to be regenerating the bone, it's going to take 6 months, and the soft tissue graft is going to thicken the flap. Okay, so that's how you do the insurance that it's optimal condition. But I have to warn you, because most people who talk about immediate implant placement, they're talking about flapless. And flapless should only be done, in my opinion, when there's really perfect bone and when there is perfect soft tissue. And then you still, as you see in the patient of today, then you're still doing a socket graft and you're still doing a connective tissue graft to compensate for some of the tissue that you're going to be losing in the healing. Okay. I hope that answered your question. Then we go to Madel. What if during the tunneling technique you damage a little bit your flap? How to manage this? So Madel, you're probably asking if you have a little error and your scalpel or your tunneling instrument perforates the flap, and you have let's say like an unfortunate situation. That can happen, although like of course with experience and with very meticulous work and with good instruments, you gotta have really microsurgical instruments. It's something that like, you know, will happen probably very little. I'm very concerned about it, so that's why I do very meticulous work. Of course, I do not want to perforate, but if you do perforate, I don't think it's the end of the world, because you'll continue your tunneling procedure around the area where you perforated. So like, you know, you can continue making a nice tunnel. And then the area which is perforated, hopefully minimally, you will support that again with the connective tissue graft. And then you might have to like do like a mini suture, like a 5-0 or 6-0 suture to close that perforation. Okay? So this is what we call microsurgical implant surgery or microsurgical periodontal surgery.
Okay, thank you.
Okay, you're welcome. Okay, from Carl. The on-one low-profile titanium abutment versus zirconia abutment. Is there an aesthetic concern for show-through? And also, is there any difference with respect to gingival response plaque accumulation? Yeah, so those are good questions, Carl. And I would probably say that both questions are, the zirconia abutment I'm in favor of that, because obviously it has a better show through of the color, so there'll be less gray shadow, and there's also going to be probably a better soft tissue response to it, because the idea of the custom zirconia abutment is to make the gingival cuff, so like the height of the abutment which is going through the gingiva, about 3 millimeters. So the temporary will only be either at the gingival margin or slightly below. So that's kind of the advantage. Now, the disadvantage of the zirconia abutment, which I've seen with many technicians and with many dentists that I work with, is that like most technicians will not be able to understand, unless you have a technician who you work with very, let's say, routinely, and they're used to really very custom aesthetics, they will not understand what you're trying to do, because they're asking you, well, where's your impression? Where's the gingival emergence profile? Because you are predicting the future. You're like, like a fortune teller a little bit in gingiva. But because you have placed the implant in a biological acceptable position, and you have placed it in the clinical acceptable position, you actually know already where that abutment should go. But you have to have a talented technician. The only thing that you cannot predict is the rotation of the implant. Because obviously there is a little, like hex which has to fit. So sometimes when I place an implant, or after I place an implant, and I'm attaching a zirconia custom abutment, the abutment is wrong by like maybe a few degrees. So what I do then is I take the abutment off and I rotate my implant just back or forward a little bit so that the custom abutment can fit. So there's a little bit of a hand, more like a really master type of craft detail to it. Right, so that's the only thing. And then, of course, when you go back to the discussion that I had with Joseph Kahn a week ago, and I kind of recommend you also to look at that one, because that one was really, I think, very informative and very good. It was our interview. You can see that Joseph Kahn actually doesn't like what I'm doing. He prefers to go just with a temporary abutment and then put the acrylic subgingival. And then he likes to make, after the gingiva is perfectly shaped, he likes to make a custom impression. But me, I'm coming a little bit more from a biological periodontal standpoint, so I prefer not to go back to the implant head to jeopardize the bone and the soft tissue. So I prefer the on-one, because it's a little bit higher, or the zirconia abutment. Now the on-one has the advantage that it's a stock abutment, so it's very easy, you just have to have it available. And then you make that custom emergence, like, let's say, like Joseph Kahn is doing. But then the advantage of the on-one is that you don't have to go with that temporary abutment down to the implant. You're just going above the implant, so you're not jeopardizing the bone. And Noble Biocare has done something which is kind of nice. They have changed the configuration of the titanium on the gray titanium. And so the new abutments, which are coming out, multi-unit as well as on one, have now a golden hue. So they have a golden color. So it's a little bit warmer. So the translucency through gingiva is not so bad. And of course, I'm not so concerned anyway about it because I always thicken the soft tissue so it doesn't show so much through. Okay, Carl, so there's not only one road, there's just different options. And I'm moving a little bit more the biological road, so you can do on one or you can do a custom zirconia abutment, but you can see like a very experienced master clinician like Joseph Kahn, he still does it pretty traditional, and it seems to work for him also very well. Just always have a really great technician with you, because it's going to be dependent a lot also on the laboratory technician. I hope I answered your question. From Yassine, that's a good one, and I agree with that. Does the platform of the on-one abutment, is it a little bit too wide, and can it influence our emergence profile? Yes. So Yassine, I definitely agree with that. I think that the on-one abutment is definitely more a non-aesthetic abutment. So I would call it like a premolar molar, perfect. But sometimes when you have sufficient mesiodistal distance, so central incisors, premolars, you can get sufficient width to do it in the aesthetic zone. But you got to have thick tissue. But I do agree that like the current on-one is a little bit wider for my taste. I would like it to be a little more slimmer. Okay. Peter Chen, can you comment on RM, root membrane technique? Are you talking about socket shield? Peter, can you clarify? Okay. So Peter is clarifying, yes. So the socket shield technique, we actually have a video in the guide library on the socket shield technique from Dr. Mitroni. I recommend you to see that. I use that technique sometimes. I usually don't treatment plan patients for it particularly. There's some Korean implant companies who have actually kits for socket shield, so the burrs are quite nice and long, so you can cut a root as needed. But again, we had also a discussion with Joseph Kahn about the socket shield technique. He's not really using it. I'm not really using it. But the nice thing is, if you have a root which is very fragile, and you're removing let's say a broken root, and you leave some dentin behind, certainly if it's attached to the buccal plate or the interproximal plate, it's not bad. As long as there's no infectious material there, so no nerve or granulation tissue, it's just dentin. So you could leave it behind. So you can work with this. Here got like, we just put in the chat here the link to the socket shield technique, so video link. So this is in the guide library, and you can see the link here. From Shadi, does the exposed connective tissue graft get epithelialized? Yeah, you mean the exposed connective tissue which you saw in my patient today? Okay. Yeah, so that was very, get a little bit of resorption, surface resorption, but that will get re-epithelialized for sure. I have used connective tissue grafts even as an exposed graft, so where I put it on periosteum to increase the vestibulum and to increase keratinization. And you'll notice, wow, that just re-epithelializes like a normal soft tissue graft. So there should be no problem. So there's no more questions in the chat. Let me give you a little comment about complications. So where do these implants not work when you do a case like today? One of the biggest problems I've seen is, of course, if you don't diagnose it correctly. So let's say the buccal plate is not present, and you still continue with a flapless procedure. Then, of course, the buccal plate will resorb or collapse very quickly what's left. The possible socket graft that you've placed there will just be invaginated with connective tissue, and you can develop a deep pocket, which of course then can get infected at some point. So really make the diagnosis very, very strict. So don't be too cavalier about it. This technique, flapless immediate tooth replacement, that I just showed you, you have to be very strict. The second problem that I've seen is that socket grafts and immediate tooth replacement especially have a big problem with sockets not being vascularized. Because sometimes we're removing teeth which have made the surrounding bone very sclerotic, especially when you had a root canal treatment, which is there for a long time. So if you don't take care of causing bleeding in that socket, and you put an implant in there, and you put like maybe a socket graft in there, you don't get a nice, blood flow, you don't get angiogenesis, you don't get vascularization. And then you can get necrosis. So I have seen these cases actually perform poorly. I mean, absolutely shockingly poorly when the socket graft or the socket has not been prepared. And that's why, yesterday or today, when you looked at the video, I don't know if you noticed it, but I was using a precision drill after I placed the implant, and I didn't feel that there was enough bleeding. And then I went into the socket walls around the implant to cause bleeding. And then later on, you saw that the bleeding actually was there because the white bioos content was red because it was bleeding. So that was good. And this case has healed really well. Okay, so Young Chen is a question here. We use Straumann BLT. If we follow Dr. Joseph Kahn technique of restoring the implant crown in multiple reconnections, how many millimeters of tissue lost with Joseph Kahn technique, bone and tissue? Yeah, Young, that's a question. It's probably I cannot answer you because obviously, first of all, I don't use the technique of Joseph Kahn. One of the reasons that I don't want to make these reconnections is of the risk of having some tissue loss. And also, I don't know the Straumann BLT because I'm not using it. But I think the BLT it's like a similar implant like the Noble Active, I believe. I'm not sure. But if I look at Joseph's technique, which is kind of like a technique which is being followed by many good prosthodontists, you have to remember that as long as you actually thicken the buccal plate and you thicken the buccal soft tissue, it's fine. Because you're compensating for some reduction. In my case, because I'm compensating, and I'm not trying to reconnect, I think that's also why I have in so many of my patients, really 0 to minimal tissue loss for now a very long time. I'm doing the immediate tooth replacement flapless for probably now close to 20 years. But because I've always been so involved with bone regeneration, I've always every single socket, I've always grafted. And because I've been involved with that connective tissue grafting around implants for so long, I've always placed some soft tissue in that gap, just lingually of the buccal soft tissue margin. So I've always been compensating, and that helped me a lot. We're going to come to the last questions because we actually put the Zoom meeting for 30 minutes. And so we'll extend it to 45 minutes because of all the great questions. Thank you very much. And but we'll have to close in about 5 minutes. Shadi, In the lectures, we saw ice cone technique, while other lectures suggest not to put collagen membrane inside the socket. So what do you suggest? Yeah, good question, Shadi. You will notice that, like, you know, in the guide library, we don't, or in my extraction socket technique masterclass, I'm not really including the ice cream cone technique. I don't think it's a good procedure to control the placement of a membrane. And it also, like, you don't have access. So I follow very much the surgical principles of I need to have access to what I'm doing. So that's really, you know, really, really, really important. So try to always, like, have that in your treatment. And I don't like these kind half techniques where you're trying to see what you're doing, but you can't really see, and then you're pushing the graft into the position. You don't really know where the bone is. You don't really know where the membrane is. You don't really know where the biomaterial is. So it just kind of sets you up for, like, a less than optimal result. So as I said earlier, if you want to do immediate tooth replacement correctly, you have to do it strict, very meticulous, and that's when you have success. So ice cream cone technique, I like ice cream. I like it out of a cone, but I don't like it from my extraction sockets. Okay, from Yang Chen, and this might be our last question. Would IPRF spin at 700 RPM low-end extraction help with the bioos? Okay, this is a good final question. When you look at the techniques we have on vascularization and early healing, PRP, PRF, either taken from the patient's own blood or purchased from an, let's say, pharmaceutical industry, seem to both enhance the healing early. And it's just like the angiogenesis is improved. So you have a really fast early inflammatory response and a really fast healing process in the first, let's say, 2 to 3 weeks. We use it a lot in sports injuries. And I like it also for wound healing. So if you look at craniofacial surgery, it's being used. If you look at orthopedic surgery, it's being used. And if you look at oral surgery or periodontal surgery, it can be used. So the only thing that you have to remember is that this addition of a technique is something which is not much better than good bleeding. So if you have a young patient and they have healthy conditions, they have no systemic compromised position, they have good surface characteristics of the socket site, and you have normal healthy bleeding, you know, the PRF is probably not going to do any kind of extra benefit. So it's just like, it's an exercise or it's a cost that you're doing probably for no reason. But if you have an elderly patient, or for example, a patient that you're seeing that you have low vascularization, yeah, maybe then it can help. Right? So pick and choose your additions of this here. I know some offices do it like all the time, but I think it's probably like overkill a little bit. Because if you have a healthy young patients bleeding, you probably don't need it. But for anything which is like more compromised, why not? Okay? So with this having said, I hope you enjoyed the live surgery. I mean, I will include this live surgery in the extraction socket masterclass. And as soon as, like, you know, the follow-up on this patient is there, we'll put it there in for you, okay? And then I'm just gonna share my, my screen. So for those of you who have, don't have the masterclass, Paul, if you can just share the screen for me, or like allow me to share the screen.
Sorry,
Okay,
just
there we go. Yeah, I got it. And can you see my screen? Okay, perfect.
yes, very nicely.
So these are the online masterclasses that some of you have been taking. And I hope that we're still like really in good quality. That like I hope so, because I see some of you coming back for the next ones. So right at this moment, for the topic that we had today, is obviously the extraction socket. That's like your top one to discuss this one. Then we completed already one which is on soft tissue, and we completed one on GBR. So those three are really kind of a package going together. But if you just look at the topic we had today, it would fit into extraction socket. We also have the masterclass on non-surgical restorative. So that's just like, let's say what we had yesterday, the interview with Dr. Mitroni and Giacomo Fabri. But that's not going into surgery or implants. So this is the extraction socket. So feel free to register for this. And for those of you who are members, remember this is free access. And now I'll finish here. The left QR code will push you directly to the Guide Dental website. And the right QR code will push you towards the Instagram in case you don't have those. Okay, so with this, I can say thank you to all of you for being part of it again on a Friday afternoon and Friday evening, depending where you are. And hopefully we're moving forward with this. This digital education is to your satisfaction. And I know we all are looking forward to see each other more in person. But until then, this seems to be a very effective way to communicate. So enjoy the rest of the day, and see you very soon online.